So should I start?
Yes,
Yes,
ma'am.
please.
Please go ahead.
Yes,
You can
please.
start the PPT.
Okay. So good evening, everyone, and welcome you all in this prestigious FOGSI ICOG webinar series on safe abortion and contraception. And as you all know that today's we have on a very important topic that is related to safe abortion and contraception. And I will welcome as a convener to our FOGSI president, Dr. Sunita Tendulkar madam, ICOG chairperson, Dr. Parag Biniwale, and all team. We all know Dr. Sunita Tendulkar madam. Has she joined? Probably not, because we all are here in some conference. I just see whether madam has logged in or not.
Yet to
So
join, ma'am.
yeah. So Dr. Sunita Tandawakar, we all know she is the president FOGSI currently 2025 and ICOG, and she's doing a lots of good work with whole FOGSI team. So thank you, madam, for your blessings and for your continuous support. Then we have with us none other than our chairperson ICOG, Dr. Parag Binewale, who is the senior consultant OPGY Pune. PG teacher, unit head, chairperson ICOG, and a very dynamic and approachable and academic person. So I request Dr. Parag Beniwale sir, so please welcome and say words of blessing.
Yeah. Thank you, Bharti. Good afternoon. I bring greetings from ICOG, and it's indeed a pleasure to address everyone for yet another episode of ICOG webinar on safe abortion and contraception. I must appreciate the efforts put in by the conveners, Dr. Bharti Maheshwari, Dr. Shobha Gudi, and Dr. Ranjana Khanna. Bharti, the program today is excellent. You've chosen the people who are currently working and who worked in the past in the field of safe abortion and contraception. So I'm looking forward to an exciting session. I welcome two very prominent personalities, Dr. Jyoti Bindal. Thank you, madam, for joining. It's a pleasure to have you with us. And I can also see Dr. Sunita Mittal, ex-professor and head of at AIMS Delhi and past vice president of FOGSI. Thank you, Madam Sunita Mittal, for joining. And in fact, we look forward to some nice inputs from you all while the program is going on. Both of you have contributed immensely to the field of safe abortion and contraception. So your words of wisdom would certainly add a value to our delegates who are listening to this program today. So on behalf of ICOG, once again, welcome all, and let's begin with the program. Sarita is also here, so Sarita can say a few words.
Yes. Thank you, Dr. Parag sir. Now I request our secretary, Dr. Sarita Balerao madam, to say a few words, and Professor Suveda, yes, ICOG
you.
secretary, Dr. Sarita madam.
Thank you, Dr. Bharti, and I think Dr. Parag has said everything. So I know that everyone is very eager to listen to this excellent program. So I just take this opportunity to wish the program all the very best and to tell our delegates do have a lovely evening and enjoy all the deliberations.
Thank you, Dr. Sarita and Dr. Parag sir, always for encouraging all of us to do good programs. So now Dr. Suvarna is not here. So once they will come, they will give words of blessings. Dr. Ashok Kumar sir, are you there? Sir is also not there. We all know that he's a very academic person, always support us as a ICOG chairperson elect. So now come to another next session. Yes. So we myself, Dr. Bharti Maheshwari as a convener, then Dr. Shobha Gudi and Dr. Ranjana Khanna. We all are together here for this important session on safe abortion and contraception. So first session we start, and for the first session, for the Dr. Ashish Kale is the speaker, and we all know that our chairperson will introduce Dr. Ashish. So the first session chairperson, please introduce the slides of Dr. Chairpersons, Dr. Meenu Agarwal. Dr. Meenu, are you there?
Yes, Bharti, I'm yes.
Okay. So our chairperson, Dr. Meenu Agarwal, and we all know that she is a president, Pune Obs and Gynae Society was in 2023-24. Anshi, the VP elect and Chairperson Imaging Science Committee of FOGSI. Very academic, dynamic person, Dr. Meenu Agarwal from Pune. Next chairperson is Dr. Please, next chairperson. Dr. Geeta Balaskar, we all know her as a professor in the Mumbai, as well as we know her as a past editor of Chief Journal of OBGY of India. So we have both chairpersons. So now I request chairperson to introduce a speaker for the first topic.
Thank you, Bharti, for this nice and nice introduction. And let me, first of all, thanks to you, to Dr. Shobha Kudi Madam and Ranjana Khanna Madam for organizing such a nice webinar on family planning or MTP and other things. So, Ashish, introducing Ashish is a difficult task because if I want to introduce him, I will take, your all the time will be gone. He's a Family Welfare Committee Chairperson, FOGSI 2325. He's a treasurer of ISAR. He is, he's a star of POGS, very dynamic, very academic, and very social. So on all fronts, and he has received many awards like Legends of Gynecology by BOGS, FOGSI Badlav Award, IAG, AAGS Skill Excellence Award, and many more awards, including the Young Achiever Award in 2017. And 8 years later, also he can still receive a Young Achiever Award because he looks as young as he used to look 10 years ago. So this is our Ashish Kale, and we are looking forward to listen to you.
Dr. Geeta Balaskar, are you there? So Dr. Geeta, are you there? Okay, I'm not able to hear them. So I request Dr. Ashish Kale.
So while he's joining, also thanks to Dr. Sarita Bhalera, Madam Parag here. So we all are, nice to see everyone. And ICOG, I have conducted one series of infertility, and that was huge. Dr. Sarita Bhalera, Madam, thank you very much for giving me that particular series. I still remember the way we worked together, and it is really nice to work with ICOG team. Thank you. Thank you, Parag.
You need to call Ashish Kale if he has not joined.
Yeah, I am not able to see him.
Sir is there.
Where is he? I can't see him.
Who is there?
iPhone Pro 14 Pro something.
No. That is Ashish Mukhopadhyay.
Dr. Basab or Dr.
Then I cannot see anybody.
Karkoti, sir. Dr. Kiran, are you there?
No, he's also not there.
I am also not able to see them.
Bharti, you can call Ashish till then. Till then, we will request Dr. Sunita Mittal to say a few words.
Yeah. Okay.
Hi, everyone. I'm there.
Thank you.
Madam Sunita Mittal, please.
Thank you, Dr. Parag. Thank you so much. I thought younger generation doesn't even recognize me. But it's very good. I just found the topic interesting, so I logged in. I thought, let's see what is the update on safe abortion and contraception. And I'm sure you people are carrying forward the torch very well and doing a good job across the country. And
So
of course,
nice
I
of you,
do
madam.
feel happy when I see that after introducing emergency contraception and medical abortion, a lot of at least mortality related to unsafe abortion is coming down in India, which is a very good thing. And I feel happy about it.
Madam, we are happy that you're here because you've done.
Thank you so much.
In this field. So it's our pleasure to have you here, and we would be happy to have you again and again for all these programs related to safe abortion and family planning. Thank you so much for joining. Yeah, maybe
I think can you
say a few words, Madam Jyoti Bindal?
if the chairpersons and conveners permit, we can take the second session
Sorry,
first.
I missed. You were saying something, Parag.
No. We just want you to address the gathering. We are waiting for the speaker to join. He's somehow not joined. So
Okay.
we thought
So-
since you are here, we would some have words of wisdom from you.
So actually, it's an honor to be a part of this, and I'm here because I'm so happy with the kind of topics ICOG is choosing for these kind of webinars. And in all honesty, I think the timings are also perfect for all of us to join for the academic feast. Having said that, specifically about today's topic, because in many ways this is becoming a little controversial, and we'll all be very happy to have the insight of the speakers, the chairpersons, about clearing the doubts of the people who are joining. I think I just need to wish all the best, and I know that so many learned people are already here. We would love to hear from them. Are our chairpersons here?
Yes,
We're waiting for the speaker to join.
Yeah, but let's hear from the chairpersons in the meantime.
yeah.
Can I say something, Parag, while we are waiting for the speaker?
Yes, please.
Yeah, since you people are heading all these committees in ICOG, it is high time that we push that second trimester medical abortion is also made legal in this country. I was discussing with some people in ministry also, but since I'm not in any position at the moment, we really need to push it. And I think FOGSI and ICOG can push it. People are using it rampantly across the country, but it is not legal. They don't know what is the correct regimen. They use any regimen they like to use. So I will really be very happy. We have recently published a paper on second trimester abortion, if they want Indian data for that matter, because we did this study actually from 9 to 24 weeks. So we included that gray area also, so they have enough evidence now, and we should work towards making second trimester medical abortion legal with a standard regimen across the country. Please work on that. I'll be very happy. Ma'am, I just had a comment on this. Being a member of the state PCPNDT and Gwalior PCPNDT committee, you will not believe, very recently, about 10 days back, we actually caught somebody, again, the sex determination, the illegal abortion. And once we make it, if it is made legal, I agree with you 100% that whenever they are done, there should be a set protocol. But to make it rampant, to make it legal across, there is a fear of being misutilized. They're already doing it. We can't avoid it. So why not give them the correct regimen and use a safe method and make it legal rather than illegal? I agree with this that a standard regime should be there. Yeah. It should be used whoever does it once they get the okay from court. Nowadays we are taking it to court permission. But if we make it legal, right now, as I said, in Gwalior, we recently caught a gynecologist and we have filed the case, FIR has been lodged, all that just because. And once it is legal, then because second trimester ka hi in log, they do it much more, the illegal abortions. No, second trimester abortion in any case is legal now till 24 weeks. We only need to legalize the medical part of it, medical aspect. And mostly across the country, it is medical abortion only being done. Very few people are going in for surgical or intraamniotic now. Everybody is doing medical only. Yeah. So that's why I think we need to work in the country towards making it legal, like we did with the medical abortion for first trimester.
I agree totally with you, madam. Most of us are using MIFE and MISO combination for second trimester.
So maybe initiate something. We consolidate all the evidence available, get in touch with drug controller and make it legal in this country now.
In the audience, we have two persons who are going to be vice presidents next year. So Meenu and Vidya can take this up, and Bharti, as ex-chairperson of MTP committee, can also contribute to this actually.
Sir, Dr. Parag and Dr. Jyoti Madam, Dr. Sunita Madam, Pranam, Dr. Bharti Maheshwari here. And I have met you personally many times and really, and for last 5 or 7 years, really worked or in fact observed many things related to abortion related issues of women. And ma'am, in my tenure in 2021, when MTP Act amendment has come, so I was the part of that situation and issues that was related, and I have explored all over countries, the FOGSians as well as women, as well as CMOs, as well as administrators. So what I have found all over the countries, lots of lack of awareness about the legality of abortion, as well as even doctors about how to maintain documentation, what is law, like what very common issues I have found that no one is not very much clear, even sometimes in the CMOs and different state administrative authorities, that whether the sites where the MTPs are allowed or the person have taken approval, whether it should be renewed every year, whether 5 years or whether never. While in the documentation it is written that once it is approved, then it has not to be renewed. While in the PCPNDT has to be renewed for 5 years, but not for the MTP sites. So that was clarity which was done by lots of discussion with lots of persons. Then other things what I have found the difficulties for our obstetricians, that they related to documents like PCPNDT and MTP, lots of confusion. The teams are coming for the PCPNDT inspections and they are exploring about all data of the abortion. While during my tenure, when I have explored lots of things or the government's guideline, I have found very clear in the government guideline, though the MTP safe abortion services should not be jeopardized in preventing sex selection. Abortion is not legal for a sex selection, but it is a genuine in certain cases. So abortion word should not be stigmatized. So I have found that these issues, that unsafe abortion, mainly women goes for the unsafe places because of social stigma, because of that PCPNDT and female feticide, such type of blames on the obstetricians as well as on the social status also. So in the 4 5 year scenario has been changed. Now I come and lots of clarity of many obstetricians about that how the site should be approved, what forms they have to be filled. Form 2 has to be regularly sent to the head of the CMO from every hospital, and then consent has to be taken on the form C. Lots of things are cleared. But once the 2021 amendment has been come, so first, that is very good relaxation that we have got extension of gestational age beyond 20 weeks. That was needed in many cases. But it also has happened that once we are terminating beyond 24 weeks, if baby is live, baby is viable, then what has to be done for that baby? So lots of issues. And in many states, still medical boards, they are not forming well. So they are not knowing that how to deal these things. But again, what I came to know, Nilima Dekhna, whether sir has joined, so I think we will start. So last thing is that now this is the time that in 1.5 hours, I have, as Dr. Parag sir has given us an opportunity to plan this webinar. So we have planned that we will discuss not, of course, abortion is very much related to the contraceptions, and we all know family planning services, how it should be becoming, should we make it more popular, how it should be acceptable and accessible to everyone. So we have made the first topic, what is the current scenario of family planning in India? And that was none other than a speaker is Dr. Ashish Kali, the currently family planning chairperson. And I hope that he will do justice with his topic because he is currently working all on this direction. Second topic, Dr. Kiran Kurkoti, he is joining very recently in the 2 3 minutes, that he will talk on the first trimester MTP, because it's still the first trimester MTP. If we do safely, if we can do it's timely, then we can decrease the abortion related complication. Many one wants to know ki what is the form has to be done, uh, why, what are the safe ways and what the complication they can have. So that Dr. Kiran Kirkoti will tell very well. And then the Dr. Basam Mukherjee is the third topic he will take. And that is also very important because we want to know that, of course, when the Mala and Maladi, we know that they are the oral hormonal pills, lots of non-oral lots of non-hormonal pills, lots of low-dose pills. So what is actually the thing that we can attract our clients and our population so that they can have these contraception. So in next few minutes we will have very good chairpersons also learn it. Dr. Ashish Mukhopadhyay, Dr. Professor Upma Saxena, and all. So I think we should start now session, and I just check whether speaker has joined. And in the last, I am just checking the participants and in the last I have panel, and because I am just kept very important questions in the panel, not that we are having in the book, but very clinical, practical questions, and all panelists, they are very expert in their field and they are from different states. So I know, sorry for inconvenience that it has become little late because of some technical errors from the speakers. So I just think that should be started in few minutes. Till that, our chairpersons, Dr. Ashish or Dr. Upma, they can give some information to our audience related to abortion or contraception.
Can you hear me, Dr. Bharti? Dr. Upma here.
Yeah, Upma.
So myself, I'm a fetal medicine specialist, and we have in Safdarjung a medical board. So any anomaly diagnosed after 24 weeks, it's within 3 days, the board sits and they give their verdict so that the patient can go ahead and whether she is allowed or not allowed, depending on that. So now I think in many places, it has become very easy for the patients to approach these boards, medical boards, for termination beyond 24 weeks. But there should be a valid reason. And regarding the misoprostol, I think there was some madam was saying, Dr. Sunita, ki still in India, people are using less of misoprostol for I just join in between for abortion, second trimester, first trimester abortions. Dr. Sunita, and we have FICO guidelines, and we are using left and right in Southern also for using meso only for termination of second trimester pregnancies.
MIFI and meso is the standard protocol.
Yeah, it's a very standard protocol, and there is no controversy.
Unless it is a missed at whatever time, then only meso is good enough.
Yeah, meso it's very safe. And but I just want to add, in our hospital in scarred uterus, if previous 2 scars, we are using even mifepristone 1 TDS for 2 days, and it's very effective because we are sometimes scared of using meso because of the risk of rupture in case of scarred uterus. So in this case, if patient lands up in second trimester, we are using Mefi TDS for 2 days. I know it's not approved, but it is a very safe regime, and it's very effective.
In fact, Upma, Dr. Sunita Mittal was suggesting that we should have a good data, which would, there has to be a standardization of protocol. Now, for first trimester termination of pregnancy, we have standard protocols in place, but people are not using the same protocol for second trimester termination.
Actually, sir, Dr. Parag, we are having it, FIGO, and we will follow it from 12 to 26 weeks, 24 weeks, we use 400 microgram TRT to 4 hourly. So we follow FIGO, and most of us are using that standard protocols. I think we can have our own FOGSI guidelines. I think that will be more widely available. Maybe people are not aware of FIGO guidelines for misoprostol. And it's a wonder drug, miso, we all know. It has made our life so easy. Earlier, we used to have so many MTP perforation just by using meso for if we are doing a suction evacuation. The os opens and the MTP becomes so easy if we are not doing medical abortion or doing suction evacuation.
Dr. Upma, what I have observed that, of course, that's why we are doing the awareness not only about the legal part but also the clinical parts of the MTP. And what you have said, though it is very clear, what I feel that dosage protocols by WHO or even by FIGOs, and that are acceptable to many of us. But of course, every patient is individual, so like sometimes you have to tailor the thing. Yeah. So, like nowadays, scarred uterus is very common. So, our very audiences, they want to know that what is the data about the scarred uterus, how you give the dosage, and also that would be discussed. We are getting time to time. So, that is what I will like to say, that those this is very clear things, and these complications can be avoided by simple awareness about all these things. So, this is our duty of all obstetricians, that we should update ourselves and our teams and all that. We should avoid even the safe abortion providers. They should update ourselves in the all clinical skills so that abortions can complications can be avoided.
There should be
But
no mortality because of abortions, because of MTP. There should be no mortality. We should try for that. Still in India, we are having maternal deaths because of MTP.
We'll have one comment from Professor Ashish Mukhopadhyay. I think Dr. Bashab has joined, so we will request him to.
Doctor, yeah.
Ashish's comment, we want you to start the session. The first speaker has not turned up.
Yes.
So we would be
I
happy.
request to, if the chairperson agrees and the conveners do agree, then we can bring forward the second session first.
So we'll take Bashab's first, and then we can.
Then Dr. Kiran Kurkoti will join, and if Dr. Kale comes, then it's okay, because maybe he was in traveling or flight. There could be some issue.
Good morning,
So,
Dr.
should-
Bharti.
Sir, has
Yeah.
joined.
Morning,
Yes, sir.
Lakshmi. Morning, Dr. Upma.
Good morning.
Jyoti, everybody. Pardeshi sir, hello. And Parag,
Bharti,
hi.
let's move to the third session now.
Yeah.
So invite Dr. Pardeshi and Dr. Upma.
I think Kiran has already joined.
No,
So,
Yeah,
Kiran sir
Dr.
has joined.
Kiran also come.
so take the second session first, please.
No problem.
Yeah.
No, I think Ashita, I have to leave. I need to take the third session first, please.
Okay.
I'm here at this FOGSI South.
Even I have
Yeah.
just come from there only. I
We
heard
all are
that
here,
you are
sir.
arriving.
We all also
We are in different
of the
rooms.
south.
just reached now.
I've just been called for something. That's the reason why I was okay still now, but just now I've been called for something.
So our chairperson of this session, Dr. Rajendra Pardesi sir, we all know that he was a vice president of FOGSI, very academic and faculty at the FICO also, and he was the faculty in the AOCOG 2011 and AOCOG at Bangkok, the international and national his credits, and we request Dr. Pardesi sir to please introduce this session on MTP and contraception.
Hello. Good
Please
afternoon,
introduce
everybody.
Dr. Upma also, so that both of them can take
Yes,
the
sir. Good afternoon, everybody. I think there is no need to introduce Dr. Basab Mukherjee.
Ma'am, sir, Dr. Pardeshi sir, Dr. Upma is another chair. Dr. Upma needs.
Yes. So Dr. Upma, Dr. Basab, Dr. Bharti, Dr. Parag Beniwale, and all office bearers. So Dr. Basab Mukherjee, he was VP FOGSI. He was member of Safe Abortion Committee of FICO. He was president Bengal Vijay Society, secretary IAG Bengal chapter, many awards and accolades, and he was office bearer of many conferences that UA FOGSI, Endogyne, Boxcon, AICOG, Vision, Wisdom 2024, AICC, RCUG, many. I think, and he is a master in this. So that's why the name Bas Ab. If we will not stop him, so he will continue only. Bas Ab bolna padta hai. So I would like to invite to guide us on hormonal contraception. So now,
Thank you, Pardeshi sir. Thank you,
Yes,
Dr. Upma. Thank you, Parag. And just want to start sharing the screen. Just a minute. Thank you. So over the next 15 minutes, would like to take you a journey on something which we all know, but just to get to some updates of over the last maybe decade, not so much in the last year or the last 6 months. Contraception changes take place over time. So let us just go through some different aspects. Yes, it's too short to cover the entire thing, but we will not try to do that. We'll try to use some aspects and have some discussion which will be meaningful for the audience here who have joined. So choosing a pill for contraception, hormonal versus non-hormonal. This talk is on hormonal oral contraception, regular use versus emergency use, and combination of an estrogen and a progestogen versus progestogen alone. So I want to start this talk a little separately, talking about contraceptive counseling. I think that is where a lot of contraception use starts, because we sometimes assume that the person won't understand. After explaining for 5 to 10 minutes, she'll say, doctor, whatever you feel like, you tell us and we will do. Or sometimes she doesn't even absorb, and she, even after hearing a lot of things, will not accept any form of contraception and will leave the clinic without using contraception and getting an unintended pregnancy. So contraception counseling is a key. And whenever we talk about counseling, one of the studies and one of the research which comes into the mind is something done by our own Dr. Nozer Sherier, who led this multicentric observation study of 825 women in 18 to 40 years age group, which was a reflection of the SELECT study which was done. And what it essentially constituted was structured contraception counseling. Now, this may take some amount of time, but at least it came on to prove that if you have structured contraception counseling of all the available methods, generally the woman will choose the most effective and the hormonal method. So structured contraception counseling using a standardized protocol and aids, which most of us have in our clinic, resulted in women increased selection and uptake of modern contraceptive method. So it's not that people will not understand, but it's just for us to give some more time, some more focus. And now with the advent of AI, there's a lot of other things which you can use in the waiting room, in the patient, for the patient in front of you, so that they can make informed choices on what to use and why to use it. So this is the results of the study which came over. The women who had not decided before the counseling finally decided. Many of them chose combined oral contraceptive pills. Some of them chose DMPA, and even the LNG IUS use also increased, just to show that the non-hormonal use came down, that if you have a structured counseling, if you have a way to talk to the patients for contraception, there are people who will be making the right choice and making the correct choice. The other point which we like to make is making the right contraceptive choice. There is several issues which come into the mind when you first talk about contraception to a woman. It could be something related to medical diseases, lifestyle factors, and family history. WHO MEC, or medical eligibility criteria, will come into a minute. Associated gynecological diseases, if she's already having them, then how to tackle them, and also the very concept of additional uses of for contraception beyond contraception. And the use of COCPs is contraindicated in estrogen sensitivity. Will come to that when progestogen only pills can be used. Extended cycle is now more commonly used than before, especially in cases like endometriosis. Cost, availability, accessibility, and personal choice all differ. And so there are different issues which help us in trying to find out what is a contraception. This was the medical eligibility criteria in 2015-16 before the app came up. So this is what it looked like. So you had a fair idea about which one to use. Category 4 is an absolute no-no. 3 is borderline. 1 and 2 is for general use, and that's for breastfeeding and different conditions. And COCP, DMPA implants, a lot of things are there which would generally be which would be reconsidered. Similarly, there are other things like unexplained vaginal bleeding, to the cancers, to the breast disease and everything. So WHO medical eligibility criteria since 2015-16 has undergone changes, and now it's available in the form of an app. So application which you can download. It just looks like this: Contraception, World Health Organization, which once you open, it will make a very good reading, because they'll be coming like eligibility tools, methods, additional info, how to use the tool. And this dark blue, not the light blue one, the dark blue one is what gives you a fair idea. Once you put in the data about what she has, what is the best contraception, or what contraception you're choosing, which category it falls into. So once you know that, it will may help the clinician to know which one to give or not to give. And even you can show the patient that this is what WHO is saying, then she also won't be afraid to use it. Coming a little to the estrogen, progesterone components of COC, how it's changed over years. So we know that from the levonorgestrel, which would be the first or second generation, people would call, we had the desogestrel, which was the third generation, and then the drospirenone, which was the fourth generation. So when drospirenone came into the market roughly 10 to 15 years ago, they used to say that this is the fourth generation, this is the best, and they had some advantages of each one, which we all know in our clinical practice. So, and we'll come to that in a moment after some time. So estrogen, the one more point is estrogen valerate versus ethinyl estradiol. So it's a synthetic estrogen versus a natural estrogen, but some people say now that valerate and estradiol have almost the same effects. But there was one time when people said that valerate has some advantages over ethinyl estradiol, which is most characteristically used all the time. So one place where estradiol valerate is extensively used is the quadriphasic regime, which is 26+2, which has been FDA licensed for AUB. So we'll talk about that in a moment also, but that is something where estrogen valerate seems to score. But traditionally, most of our oral contraceptive pills have ethinyl estradiol, and that has been used along with different progestrogens over time. So we've seen from levonorgestrel, which may be your standard drug, to drospirenone, which is the most modern one, and of course Dynogest also, which is used specifically in endometriosis mainly. The other, as we said, the E2V DNG combination 26+2, and this has some other favorable effects which over the other conventional pills, and something with the VTE risks and the lipid profile too. There is another estradiol E4 DRSP, which is also in discussion. Extended cycle is just taking the pills together and having them back to back and having a less of a gap. Especially it's for people who do not want to have periods. It's socially, they don't want periods will disrupt their occupation or their way of life, or if she has some disease along with the periods, mainly due to pain, dysmenorrhea, then she would have to have less frequent number of periods. Monthly ring, this is another one which again hasn't been so popular since it has come. Low and ultra low dose. Now again, a lot of people would say we have drospirenone 20, we have drospirenone 30, which one to use. So last around 10 years since the ultra low dose has come in, a lot of us think that that is popular. The only thing is the unscheduled bleeding or breakthrough bleeding, which sometimes may be troublesome. So sometimes people start with the 30 and then go down to the 20, which is reasonably all right. Some people even step up if she has a problem with 20, which may be seen in 10 to 15% of cases. Sometimes you can reassure her that it will settle like a lot of other bleeding, but sometimes it may be persistent and you may have to either change the medicine, increase the dose, or look for some other problem which you may have encountered. So no change in contraceptive efficacy, that's all fine. So if you lower the dose, that doesn't mean it doesn't work. And this is something which has been recommended and been nowadays quite frequently used. So the 20 microgram ethinyl estradiol is well tolerated, brings significant improvement in quality of life, subjective symptoms, better cycle control, less unacceptable bleeding over time. So this is DSG and LNG combination comparison. So the DSG is slightly better than the LNG, and the ultra dose DSG and drospirenone and the desogestrel are effective, acceptable, well tolerated, and slightly better, you say, metabolically friendly than the LNG. So progesterone generations, I think all of us have gone through this slide several times in several forms, and we know that the third generation, especially cyproterone, has a very potent anti-androgenic action. That's why in a PCO woman, if the androgenic features are the most prominent, we would like to start with cyproterone for some time with a combination of course, estrogen. And if it's the bloating and the mineralocorticoid symptoms, then we would want to start with drospirenone later possibly. But cyproterone cannot be given forever, so you have to stop it at some time. And this is a slide which desogestrel has shown us. From the time desogestrel has come, we've seen this slide many times, where selectivity index, how much it sticks to the progestogen receptors, depends on different how the actions of different progestins are. So a higher progestogen activity and a lower androgen activity keeps on happening. Destodine also features here. Progesterone only pills, I think this is something which traditionally 20 years ago we used to think only in the postmenopausal status. We still do that in the current practice, but there are other times where we can use it instead of an estrogen. The only issue, of course, with any progesterone only contraception is unscheduled bleeding, and that has to be tackled. So some people may give ormeloxifene with this, or some people may see whether she's having a problem and then decide whether to continue with the same. But this is some people who are intolerant to estrogen, or have a problem with estrogen, or have a very high medical diseases to which contraindicate the use of estrogen, then they have to use progesterone pills. Is one option for them, not the only option, one option. Yes, you can use LNG-IUS, which is a more common option because it will be a long-term effect. But if she doesn't want to use, you can use DMPA. That's one option. Again, it's all depending on what the woman chooses at the end of the day, but this is just one more choice. If she takes this, then we have to explain to her. We already mentioned the extended cycle pills. There are fewer intervals and less, either by personal choice or for medical reasons. And non-contraceptive benefits, we already know some of them, just putting them all in a slide. PMS, you can have some benefits with drospirenone, especially the 21, where you have a shorter hormone-free interval. Endometriosis, besides the extended cycle, which can be through everything, the Dynogest works very good, and the Dynogest estrogen combination. In AUB, we know the 26+2 regime of Dynogest and estradiol valerate, which has been given the FDA approval for use in AUB, is becoming slowly quite popular. Yes, it's costly, but a lot of things are costly in the medicine world, and so this is something which is picking up pace. PCO, as I said already, cyproterone or drospirenone is your choice. But drospirenone, generally, we know is the most commonly used oral contraceptive worldwide. So drospirenone containing OCPs are the most common worldwide. Just one highlight for FOGSI, what FOGSI has done in the field of sexual and reproductive health over the last at least 10, 12 years till from the time I've been associated with the Family Welfare Committee. We have seen how first Dr. Mandakini Parihar to start with, and then Dr. Ritu Joshi, and then subsequently Dr. Yashodhara Pradeep, Dr. Shobha Gudi. A lot of people have done a lot of good work, of which the MTP Amendment Act was one of the things where some of the people were also called along with the MTP people. Expansion of the contraceptive basket, we were very much involved, at least for 5-7 years before this 2016 introduction of basket of choices came in. A lot of lobbying was done with the government of India at the Ministry of Health and Family Welfare, with a lot of other NGOs. And a national level, a lot of prizes. A lot of focus of FOGSI is on contraception and family welfare. We have prizes on population stabilization and the continuous working with NGOs, partnering them. And now Ashish is doing a wonderful job in that way, Ashish Kale, for working in SRH. Last slides, family planning to 2030 FP. So India's vision for FP 2030 is to provide high quality, comprehensive family planning services to women of all reproductive age group, including those from the marginalized groups. And one of the ways of doing that is the Mission Parivar Vikas, which is their flagship program of the Ministry of Health and Family Welfare, where a lot of the districts which are hard to reach have been identified, and they are the ones which have been having a big focus on how to get family planning along with other healthcare packages in that particular area. So a lot of exciting times ahead. The takeaway messages: hormonal contraception is one of the popular birth control methods worldwide. For most of us, I think the focus would still be on awareness at different levels. One would be at school, college, for having sexual reproductive health awareness generally there. One would be at even at corporates, wherever you want to talk on this, and also at among our own peers, where people still have misconception that contraception cannot be used after 40, or when can you stop OC pills, till what age can you use it. and a lot of other misconceptions which we can all discuss. Periodic evaluation besides troubleshooting, and the MEC app should be in everybody's phone whenever you're in doubt. Counseling for clinics, as we said, were our first point. It would be the way forward, and to take that little bit of time which could make a big difference. Thank you all. Thank you very much.
Thank
Thanks, Dr. Parag.
thank you, Dr. Basab. So thank you so much for this talk. So extremely sorry, I was not aware that Dr. Upma Saxena has been introduced. So first I will introduce Upma Saxena, and
It's
then
okay, Dr. Basid.
Upma will comment on this. Upma is professor consultant, VMMC and Safdarjung Hospital. She is fetal medicine specialist. She is hardcore teacher since 3 decades. See, 200 plus papers, 400 plus citations, 100 books, and WHO fellowship. I also heard many times, and just I will tell you one biodata. My wife, she is known to you, means she doesn't know to you by fetal medicine. She was telling that Dr. Upma is giving very nice talk on prediction of placenta, creta spectrum, and fetal intravenous cyst. Many lectures, but she is expertise in that more than that. So, madam, I would like to invite you to comment on this talk.
So, thanks a lot, sir. I want to thank Dr. Basa for a very lucid presentation. I think in 15 minutes, he did total justice to oral contraceptive pills. I just want to add, he beautifully highlighted this structured counseling. So counseling is very important. So when I want to put one thing, when I'm counseling for COCs, our patients are a little hesitant. So if we tell them the contraception returns, the fertility returns fast, and the contraceptive effect goes up the moment they stop the pill, it goes a long way in their thinking for starting these pills. And for the patients who want to conceive fast, I mean, their first time they had abortion or just one pregnancy earlier, we usually start them on COCs. And besides contraception, we all know they have added benefits. So, and we can also tell our patients if they are using for AUD, that they can use it for even 5 years down the lane. If they are using, if we are also using in patients who have done myomectomy in young women and who are not keen, unmarried women for where we have done myomectomies, so that doesn't require endometrioma drainage. So COC is a wonder drug. Only thing again is the counseling. Again, I want to emphasize this WHO MSc app. Every youngster should have it, because it was not there in our time. So definitely there are some contraindications, but if we just follow this app, we can avoid those patients where we can't give them. Otherwise, it's a wonder drug. Thanks again for inviting me to this wonderful webinar.
Thank you, Dr. Upma. Thank you, Pardeshi sir. Thank you, Parag and team. Thank you, Bharti. Bharti is the one who did all the calling. Hi, Dr. Kavita. Hi. See you again.
Thank you, Dr. Bharti, Dr. Parag Beniwale. Thank you.
Thank you.
Hello, can you hear me?
Bharti, Dr. Kiran has joined. So I think let's have Dr. Minu and Dr. Ashish to chair the session, and let's request Dr. Kiran to start his presentation.
Yes. So thank you very much, all of us. Very fruitful topic, and told by Dr. Basab. I think I can see now Dr. Kiran Kurkoti. Dr. Kiran Kurkoti, sir, you are here. So I request our chairperson to invite our next speaker, Dr. Kiran Kurkoti.
Yes. Can I introduce him?
Yeah. Dr. Ashish Mukhopadhyay sir is there. Yeah.
So since I need to be introduced first also. So I am Professor Ashish Kumar Mukhopadhyay from Kolkata. I am the professor and principal of a medical college in Kolkata. And I have been the past vice president of FOGSI and the ICOG governing council member.
Welcome, Dr. Ashish sir, and thank you for giving consent to be here. Thank you.
My pleasure. Thank you very much, Dr. Bharti. I have always seen you working always. And my dear friend, Dr. Parag Beniwale, and the entire ICOG team. I know Kiran for a long, long time. You know, when we were contesting together for the post of chairperson, from that time only, I know Kiran. He's a very good friend of mine. And not only me, he is a friend of everyone. He's such a lovely personality. Could we have the CV slide of Dr. Kiran Kurkoti, please? I saw it in a flash and then it went off. Hello.
Yes, we can
Yes.
hear you. Yeah.
Yes, Dr. Kiran Kurkoti is the past Vice President of EMOGS and the past President of Pune Society, and also, yes.
Please stay on Dr. Kiran
Kiran.
Kurkoti, sir, CV.
I think Ashish, thank you.
Dr. Kiran Kurkoti, we all know Dr. Kiran Kurkoti.
Yeah.
He was a past MTP committee chairperson. And
Yes.
sir, we all know. Yeah, Dr. Ashish, sir, you want to say about Dr. Kiran Kurkoti?
Yeah. What I was talking about is a very pleasant personality called Dr. Kiran Kurkoti. He was the chairperson of MTP committee in 2009, and then EMOGS chairperson, MTP committee, EMOGS 2012, chairperson medical education research and training of EMOGS. He has been very closely, intimately associated with EMOGS. And in POGS, he was a committee member since 25 years and organizing chairman secretary of over 100 workshops, seminars, and national conferences. He is the director, Shashwat Maternity Multi-Speciality Hospital, India Private Limited, Sanjeevan Hospital, Pune, director of Shashwat Hospital, Awadh, Aundh, and he has received many awards.
Thank you, Ashish. It's okay. It's fine. I mean,
it will be longer than your topic.
No, that is why I said thank you. That is why I said thank you. Thank you so much. I think
waiting for the for Kiran to start on perhaps the least controversial topic, that is the first trimester MTP. So I think Kiran will elaborate on that. Kiran, the floor is yours.
Yes. Can you see my slides? Yeah.
Yes, we can see.
So thank you. At the outset, thank you so much, ICOG. Thank you so much, Dr. Parag Biniwale, Dr. Kumar, and of course, thanks a lot to Dr. Conveners, Dr. Bharti Maheshwari, Dr. Shobha, and Dr. Ranjana Khanna. But it's really a pleasure always to be in front of ICOGs, sharing the screen with so many people, so many luminaries. So without much ado, I will speak on first trimester abortions. Well, my focus will be only on the medical abortions, and I would less focus on the surgical abortions, which has been my forte. So this talk is MTP made easy for all trimesters. Well, friends, everyone knows since years, gynecologists have been performing MTPs. Since years, gynecologists have been perforating the uterus. Unless you perforate the uterus, you cannot be called as a gynecologist. It's an old saying. So this talk is dedicated to all the gynecologists who have perforated the uterus and to all the patients who had their uteri perforated, their intestines dissected and anastomosed, and to those unfortunate women who couldn't make it because of hemorrhage and sepsis. So this is the picture of a poor male gynecologist. I never show the picture of a lady gynecologist. I dare not show. Who is saying sorry to all these unfortunate women. So friends, this is the attitude of a gynecologist when he performs an MTP. That is bindas. Okay. But friends, please remember that whenever you are performing an MTP, it's like lighting a bomb, and you can't expect miracles like this to happen every time. So, well, coming to the pharmacology of the first trimester abortions, we all know that the first trimester abortion is carried out by two set of drugs. One is, of course, the mifepristone, and the other is the misoprostol. Well, mifepristone, how does it act? It is going to bind to the progesterone receptor, but it doesn't activate the receptor, and thus it will act as an antiprogesterone. So it also blocks the receptors for glucocorticoids, which is a side effect. Now, what is the action of misoprostol? So because of the progesterone blockade, once you give misoprostol, then misoprostol is going to cause rhythmic uterine contractions, breakdown of the maternal capillaries, prostaglandin synthesis, which causes cervical wrapping, and the rhythmic uterine contractions. So this together is going to cause detachment and expulsion of the products of conception, that is abortion. So this one must remember. Now here we must remember that whenever we give a combination of mifepristone and misoprostol, an interval of 24 hours has to be there, because many a times what people do is they give everything together. But please remember, it takes about 24 hours for the drug action of mifepristone to occur. And after that, once you give misoprostol, then misoprostol is more effective. Okay. Yeah. So again, coming to the basic things, that is C form, that is consent form, is mandatory for all abortions, surgical or medical. And this is the simplest consent form that can be designed, and FOGSI and of course MTP committee also advocates that you fill up all these forms to the T. So this is the form C, this is the provider opinion form. Now here, this opinion form has to be filled within 3 hours of performing MTPs. Now, in case you are doing a medical abortion, then you please fill it within 3 hours of giving the first tablet, that is mifepristone. Now, coming to Form E, we are not going to go to the Form E, but because of the amendment, this is the Form E, 20 to 24 weeks. You can do the MTP by filling the Form E. Now, method-specific counseling, we need to counsel the patients about medical abortion. That is, it is offered at an early stage, it is more private, it is more natural, no anesthesia, no risk of injury, no hospital stay. Whereas the limitations of medical abortion are 3 visits, longer process, it is unpredictable. In few cases, we can have a incomplete abortion, and of course, the side effect of the drugs. So this is the method-specific counseling about medical abortion. Another side effect is in case there is a excessive bleeding or in case there is a failure, then the patient needs to be prepared for a surgical abortion. That we must tell the patient. Also, in case the patient continues to, in case the pregnancy continues, then we have to counsel that she cannot continue the pregnancy because the drug mifepristone is teratogenic. Now, again, post-procedure counseling is she should avoid going out of the station till the 3rd visit, that is around 15 days. She should report in case of excessive bleeding. Now, please remember, bleeding and excessive bleeding should be specified to all the patients. More than 2 pads per hour continuously for 2 hours, that is excessive bleeding. So this one must remember. Otherwise, you'll continue to get the phones that I have soaked 4 pads, 6 pads, 8 pads. But you should remember that excessive bleeding is more than 2 pads per hour continuously for 2 hours. Now, these are the basic investigations which are done for all cases of MTP, surgical or medical, hemoglobin, urine, and blood group. Again, these are the guidelines. Whether we should do the procedure of sonography, well, pre-procedure sonography you can do in case the size is difficult to judge, in case the patient has undergone a previous uterine surgery, in case there is a discrepancy between the history and clinical findings. Of course, pre-abortion sonography is not necessary, but this is the WHO guideline. However, in my personal opinion, definitely you should go ahead to minimize the risk of you giving any MTP pill for number 1, an ectopic pregnancy, and number 2, many times it so happens that the patient misses 1 or 2 days and then comes for an abortion. And what we have found out is, in case the gestation sac is not well developed, and in case you give MTP pills, then it is likely that she may continue to continue the pregnancy, because by that time, in very, very early pregnancy, maybe progesterone receptors are not that well developed so that mifepristone can act. So this one must remember that unless you see the gestation sac, just avoid. Of course, this is a practical experience and not given anywhere in the literature. Okay, so yeah. So the only role of sonography is to determine the presence or absence of gestation sac. Again, missing an ectopic is always there. So that is why it is better. Although GYN-UT and many organizations and even WHO says that you do not do a sonography, but my strong advice is you please go ahead and do a sonography. Okay. Now again, doing an ultrasound, again, it is going to rule out vesicular mole also. So this is very important. And last but not the least, the incidence of scar ectopic is on the rise. So we can definitely say that please do a pre-MTP sonography to rule out all these 4 conditions. So this is very important. Now the drug regime, I mean, this is the WHO standard regime which is being given for each and every patient. So regime up to 63 days. We all know that now medical abortion is legalized up to 63 days of pregnancy in India. So the regime in India is 1 tablet mifepristone you can give on day 1. You can wait for 36 to 48 hours and then give 4 tablets of misoprostol. Please remember here that WHO regime clearly says that oral tablets of misoprostol are not to be given. Misoprostol can be given buccally, pervaginally, or sublingually. Now, my personal experience is we give everything pervaginal so that the best outcome is achieved by a pervaginal examination, by a pervaginal insertion of misoprostol rather than the sublingual or a buccal insertion. Okay, so these are the various routes of administration. Now, what to do? What after 63? That was a good talk initially. But what after 63? That is from 63 to 84 days. That is 12 weeks of pregnancy. Now, please remember that there is no difference in the regime. The regime remains the same. That is 1 tablet of mifepristone on day 1 and 4 tablets, that is 800 on day 3. So the regime is the same up to 12 weeks of pregnancy as far as the WHO is concerned. However, in India, it is legal only up to 63 days. However, I have been using the regime up to say 84 days of pregnancy, and I will tell you how I go about it, and whether it is feasible for you, you have to decide on your own. So what I decided was, I have stopped doing a surgical abortion unless and until it is dire necessary, or unless and until the patient continues the pregnancy. So what my methodology is, or how I do it from 9 to 12 weeks, is I give day 1 mifepristone orally, anti-D in case the patient is RH negative. I admit on day 2 at night, late night, I admit the patient and I instill a simple gel, that is Serviprime gel. Okay. The advantage is it works wonders as far as primary gravidas and previous C-sections are concerned. And on day 3, I give 4 tablets of misoprostol vaginally at around 5 o'clock. And along with that, I give intramuscular brutavarin. Now, please remember, this is the regime which I have derived for myself. And please believe, we have done more than I would say 3,000 cases till date. Okay. So in multigravidas, these patients abort with the PGE2 gel alone, because PGE2 gel potentiates the action of mifepristone. Whereas in primary or previous C-sections, they abort after a single dose of misoprostol by 9 AM, that is within 4 hours. So this is the regime which I follow in my clinic. Now, these are the FAQs on first trimester abortion. These are the contraindication: ectopic, long-term steroids, adrenal failures, coagulopathies, porphyrias. Again, antibiotics, whether you can give antibiotics or no, antibiotics are not mandatory. However, if there is any kind of infection, if at all you suspect a vaginal infection, then of course doxycycline and metronidazole are the drugs of choice which are advised for all cases of PID by the CDC regime, and the same thing is advised by the WHO. Again, whether to do a post MTP sonography, yes, you should do a post MTP sonography also. Now, here one must remember that if the patient is clinically normal, then even if the endometrial thickness is more than 15 millimeter, please do not call it as an incomplete abortion. Many a times the sonologists are not aware of this particular thing. So anything which is beyond 15 millimeter, they might label it as an incomplete abortion, and then the patient will come back to you. However, if the patient is asymptomatic, there is nothing to be done in such cases. And we can do only a vacuum aspiration in case the patient is symptomatic. I'll come to the RPOCs later. Now, these are the complications. True drug failure, it will occur in less than 1% of women. And what is true drug failure? Continuation of the pregnancy or cardiac activity 15 days after MIP and meso administration. Now, in this particular case, you need to do a surgical evacuation. Another complication is teratogenicity, very, very less known. And the teratogenicity, because of mifepristone, is hardly known. It only may cause cyanomelia. Only few cases are recorded till date. That is complete lack of amniotic sac, and it is associated with administration of mifepristone very early weeks of gestation. Now, misoprostol is more teratogenic. It is going to act in a teratogenic way by 2 ways. One is a mechanical way, and the other is the vascular way. In a mechanical way, what it is going to cause, it causes uterine contractions. Uterine contractions are going to result in the flexion of the cranial nerve 6 and 7 area, which is going to cause hemorrhage and cellular death of the cranial nerve nuclei. And that is going to cause the Mobius syndrome or palsy of the eyes and facial muscles. This is the result of uterine contractions. And hypoperfusion, that is less perfusion, causes hypoxia. Endothelial cells are injured, tissue lesions may be there. And this hypoperfusion again causes a subclavian artery disruption sequence, which is also called as Poland syndrome. And in case it goes beyond the cranial, beyond the cerebral vessels, then in the lower limbs, it can cause limb reduction defects or limb anomalies. Now, in case of a previous session, there are no complications. We have done many such cases. The dose and regime remains the same. Okay, breastfeeding, it is recommended that after misoprostol, the patient doesn't breastfeed the baby for at least 6 hours, because misoprostol is converted into its metabolite, that is misoprostolic acid, and misoprostolic acid secreted in the breast milk can cause loose motions in the baby. So the patient should feed the baby, then you should put in misoprostol, and then again she can resume breastfeeding after 6 hours. Again, multiple pregnancy, same regime. Now, a surgical evacuation can be done in case the woman requests. If the bleeding is heavy, more than 2 pads per hour continuously for 2 hours, if there is prolonged bleeding or there is evidence of infection. Now, coming to this condition, that is retained POC. Now, because of the previous C-sections, many a times you can find that the retained POCs are there. So again, this patient will continue to bleed or continue to do spotting. Now, here we must remember that whenever we do a sonography of such patients, it is important to do a sonography with a color Doppler, not just a plain sonography. So if at all you do a color Doppler, these are the 3 vascular types of patterns which are described on ultrasonography. So this is the vascular grading of the retained products of conception on the ultrasound. 1, type 0, no detectable vascularity. Type 1, minimal vascularity less than that of the myometrium. Type 2 is moderate, that is equal flow in the endometrium and myometrium. And type 3, that is marked endometrial vascularity greater than that of the normal myometrium in the same ejection. And if at all you see, the velocity of the arterial flow in this POCs will be more than 100. So please remember that whenever you do a post MTP sonography to determine the completeness of a medical abortion, just put in a color and see whether there are any retained products of conception. If there are nothing, absolutely no problem. Again, blood clots versus, it is very difficult for us to differentiate blood clots versus RPOCs if you don't put color. So RPCOC, as you can see, the vascularity will increase in RPOC and that will not be the same in a blood clot. Again, other potential things which can mimic RPOC is, of course, the endometrial polyp or a small submucous fibroid. So what is the treatment? So this is a new wonder drug as far as the RPCOs are concerned. There are a lot of trials, and if at all you start giving letrozole 5 mg once a day for 5 days or 7 days, you will find that within 6 to 7 days, the patient will be absolutely asymptomatic. We have done this particular trial in about 15 to 20 cases wherein the patients with previous C-sections had some RPOC, and then we resorted to giving her letrozole in the same dose, and we did a sonography after 10 days. The RPOCs have cleared. So that is one of the best things that can be out. That is one of the new things, that is role of letrozole in medical abortion. Now, what is new? So what is new is again letrozole in medical abortion. I told you about letrozole as far as the RPOCs are concerned. Now there are various trials for use of letrozole with misoprostol. Please mind well, letrozole with misoprostol where mifepristone is not available. So letrozole 10 mg per day for 3 days followed by misoprostol on day 4. This is a big trial, and it has been found that this regime of letrozole for 3 days followed by misoprostol is almost equally as efficacious as mifepristone with misoprostol regime. The second thing is cervical priming prior to a surgical abortion. So whenever we do a surgical abortion, we do a cervical priming by 2 tablets of misoprostol. The new thing is mifepristone also now can be given 200 mg orally 48 hours prior to the surgical abortion. So this is a new guideline which has come up, which was not there in the old guidelines. So number 1, letrozole, and number 2, mifepristone. So these are the 2 guidelines. Number 3 is D&C is absolutely contraindicated. This is the 3rd guideline, and we need to do a vacuum aspiration, that is the manual vacuum aspiration, in case there are any retained products, or in case you do not want to do a medical abortion even beyond between say 9 and 12 weeks pregnancy, no D&C, but go ahead and do a vacuum aspirations. So these are the few things as far as medical abortions are concerned, and new thoughts from my side. So as I said, that between 9 to 12 weeks, I think those of us who are into medical colleges, I think we should take up the trial of a medical abortion in a structured environment wherein the patient can be admitted, and we can keep the patient under observation, see to it that there is no heavy bleeding. And in case we keep her say from 9 o'clock to 5 o'clock, the standard time for a surgical abortion IPD patient, and in case the same abortion can be done medically, I think that would be a great thing for all our women, that is stopping all kind of surgical abortion up to 12 weeks of pregnancy. I think with that, thank you so much ICOG, and thank you everyone for giving me the opportunity to give my thoughts on first trimester abortion. I have not touched base upon surgical abortion because it is now a time-tested thing. MVA has been done, addressed to so many times that I don't think there is anything new as far as MVA is concerned. So I'm open to any kind of discussion, criticism, action, whatever.
Kiran, I think it's an excellent talk, and thank you very much for being so practical and so case oriented. And it looks like you have worked on this, and there are many things that we have learned today. That is also very important. Just I wanted to ask one question. We'll be waiting for the question to come in the chat box. But in the meantime, I wanted to ask you.
Yeah.
You said once that you use the gel, isn't it?
Yes.
Apparently, the purpose should be the softening of the cervix, right?
Yes.
But misoprostol is doing the same job, isn't it? So, do you think it is necessary to give it additionally, or you just?
No. What I do is I use the gel from 9 to 12 weeks of pregnancy. Okay, 9 to 12 weeks. I don't use the gel up to 9 weeks of pregnancy. Now, what happens is I am using the same regime for the second trimester, which I was using for the second trimester abortion in the 9 to 12 weeks bracket. So what gel does is, gel is nothing but PGE2. It just potentiates the action of mifepristone. It helps in opening up of the mouth of the uterus, because what happens in a primigravida or in a patient with previous to cesarean section, in case you put in misoprostol directly, the patient has got a lot of pain. If at all you put in a gel, if the cervix has been softened, then misoprostol related pain is much bearable, or it is much lesser. So that is what my observation is.
But are you comfortable using misoprostol in scarred uterus?
Yes. I have done in second trimester abortion also. I have done a lot of cases. Absolutely comfortable. And first trimester too. I said I have stopped doing I have stopped doing surgical abortion. I'm telling.
So,
believe me.
yeah.
Believe me. Karke dekho, sir.
Kiran, that was an excellent talk with lot of take-home points.
Yes, sir. Yes, ma'am.
Something I just want to share with everyone is now internationally lot of studies on hysteroscopic removal of retained products of conception with tissue retrieval system. And they have shown that I have also done a few cases, and they have shown that the adhesion rates are very, very low when rather than doing a suction. So when they have compared the two, using a suction and using a tissue retrieval system hysteroscopically, either Bugatti or Trochlear, and under vision, just it takes maybe 37 seconds or 40 seconds, and it just comes out under vision and no additions. So that is one thing
I have also done it. I have also done it in the workshop at Symbiosis, and really it's a wonder system. The only thing is cost. The only thing about that is the cost. That's all. Otherwise, it's a wonderful thing. And as far as RPOC is concerned, as I said, that I have been using letrozole also. So letrozole does similar kind of wonders.
Yeah,
so
I think that is a better, and what we learned today about the letrozole, and I think that more and more usage would follow after this. And yes, adding hysteroscopy to RPOC will be a bit costly, because the setup cost will rise, and we have over the last maybe 100 years we have created an impression in the public mind that, well, doing with MTP or incomplete abortion or this retained products of conception is just a 2 minutes job, and you should not cost much. So that is a general perception that we have created in people's mind. Now we are going to suffer from that. So that is the reason why we cannot use this expensive yet very effective procedures. Is Dr. Ashok Kumar here? I don't think he's there. I can't see him.
Dr. Kiran sir, excellent talk. And as I want that recent update, and that should be, so you complete our purpose, that being a speaker on this important topic. And as Dr. Meenu has said that RPOC can be cleared very beautifully by hysteroscope, no doubt. When you see and you remove those who are doing regularly 4, 5, 6 hysteroscopy, and in some cases then they do it, so it's a beautifully, no doubt about that. But as Dr. Ashish sir said, that in every case, if you put the hysteroscope, so sometimes it is not feasible, and in fact, it is not so useful that you have to put so much of cost to the patients and so much of things. So it can be done very easily, as we are doing by our suctions and MVAs and other things. And what Dr. Kiran Kurkoti has shared his experience on the letrozole, so we definitely will try and we will see the things that. But again, we all obstetricians are trained from our residencies to till that every case is different for the MTP as such that, so every case should be taken seriously. And other aspects, that if someone has gotten the previous MTP, they have taken some other medicines. Now patients are coming with themselves taking many medicines. So some everything is different. Some are very easy, some are difficult. So definitely ultrasound has very important role. So thank you very much. If any chairperson, Dr. Jyoti Bindal, madam, you want to say something about that? You are such a learned person are in our today's webinar. We are so happy. Yes, madam. You have so much of experience. What do you say? Message for all today's generation.
Dr. Jyoti,
Madam, unmute yourself. Madam, unmute yourself.
Yeah. I think it was a very, very good description Kiran gave. I mean, it's always a pleasure to hear Kiran.
Thank you.
But the take-home messages are very, very clear. I also agree that most of us have stopped now doing surgical abortions. This putting in the gel before putting the tablet has been used by most of us now. And as he rightly said, especially in previous two sections, especially when the cervix is firm, literally firm. These are the good cases for that. So yeah, I would 100% agree with that.
Dr. Kiran,
I'm also very happy to hear about Meenu's hysteroscopic removal study. Yeah. So I haven't read about the literature about that, but I'm sure it would be good to hear that.
Dr. Bharti, can I ask how letrozole is used for RPOC?
Yeah.
What regime to be followed? That
Dr.
seems to be very interesting. Even I want
Dr.
to try.
Kiran, another thing is that if the patient is bleeding a lot, then would you like to go in for some immediate procedure or try letrozole?
Madam, if the patient is bleeding a lot, then of course, resort to a surgical abortion.
Yeah.
Now the dose of letrozole is 5 milligram OD for 5 days. Some people are using for 7 days also. Some people are using 2.5 milligram BD for 7 days. So that can be used, and we have used it. In addition to this, there have been trials where people are using mifepristone 25 milligram BD for 5 days, even for RPOCs. So RPOCs के लिए four types of management are available. 2 medical, 1 mifepristone and letrozole. 2 surgical, that is 1 MVA, and the other is, of course, the True Clear system, which Dr. Meenu mentioned.
So if patient is hemodynamically stable, he can be sent home, and this can be given on a domiciliary basis. This 5 milligram letrozole OD for 5 days, or either Mefi for 25 milligram BD.
Absolutely.
That seems to be right, because we keep on repeating misoprostol all the time, 400 microgram. No. So we can try this.
Please try it out. Please try it out. We have done in a lot of cases.
And regarding the scarred uterus, I just want to put in first trimester, meso is totally safe. We don't have to think twice in first trimester about whether previous 1, 2 or 3 in first trimester. We don't have to think twice before putting meso.
Hello? Yes?
Yes.
Am I audible? Yeah.
I would like to conclude this session because,
So, yeah, Dr. Kiran sir has giving, I think, those, because someone were asking in the chat groups that please mention the door. And this link will be available on the ICOG website. So those who want to repeat here and they want to know all those, so they can. But Dr. Kiran Kurkoti sir, please see the chat box, and whatever you can reply, then it would be good for all audience.
Yes, madam.
So definitely, yeah.
If you
Yes,
can
sir?
share your presentation, that will be beneficial for
That presentation will be available on the ICOG website, sir. It is always available.
That's
Within
fine.
3-4 days, it become available. So,
Okay.
Dr. Kiran Kurkoti sir, you made our day, because in the first trimester MTP, we are thinking what's new. So you have again, sensitized all of us that how we can do the procedures, and we can avoid incomplete abortions and the whole things. So sir ne kuch he has replied, just do
So old
further
Kiran
जाएंगे.
with
Okay.
new regimes. Thank
Yeah.
you. Kiran.
Yes, anyone wants to add something? Dr. Pardeshi sir or any senior they want to share? Then we will move to our next session and the panel discussion. I can see the participants. So I think we've learned, Dr. Ashish Kale, you are here, then you can, it is time now. Dr. Ashish Kale, can you hear me?
Yes, madam, I'm there. I was in
So
a
आप
flight
थोड़ा short कर
when
दीजिएगा
this.
because yes, you can share your screen and in 10 minutes just because we have to finish in the 6 o'clock.
Yeah, madam, I'm in a transit, so I had shared the PPT with you. Can you able to
Okay,
share
okay.
the
So
PPT
what
so
I
that I
will
can?
do, I can see. So what I do the panel, and
Yeah,
the last 10
Okay, madam.
minutes, if you can join, then you
that's
can
better.
present your
That's
PPT.
better.
Yeah.
Yes, yes.
Okay, okay, okay.
Thank you very
So
much.
thank you very much. Yes, because you know we all are so much of busy and every place, but everyone has given consent to speak, and you all are such a senior person, so all our audience want to hear you. So thank you very much, and then we move to our next part of today's webinar, and that is very important, and that is the panel on the clinical and legal issues related to abortion. So. Team, I am sharing my screen, so I will introduce all panelists also. So thank you, Dr. Kiran Kurkoti, sir. We will continue to ask questions, whatever I will come. And thank you very much for very important topic.
Bharti, thank you very much. You are so excited. I can see that you have joined from two places, two devices.
Yeah, because I am in the such place, I can't tell you. I am also in the South conference, and I was not thinking ki in this hotel I will have some difficulties for internet, but finally I managed. So thank you for inconvenience, whatever I will trying to do. So we have a today's panel, next panel that is clinical and legal issues related to safe abortion and contraception practices. First of all, I would like to thanks Parag sir and whole FOGSI and ICOG team that they have given opportunity to me and my conveners with me, Dr. Shobha Gudi and Dr. Ranna Khanna. And thank you, we all three, they could bring this presentation for all of you. So, and we are in next, I think 30 minutes, we will do some questions. What I think are not in books, and we will do something different. So we all know Dr. Shobha Gudi is here, and she is the chairperson. She was chairperson in the Family Welfare Committee. She's from Bangalore. We all know her very well. Then we have none other than Dr. Vidya Dobi. That is, she's the vice president elect, and she was also committee chairperson, food and drug, and very professor, learned person. Then we none other hand Dr. Ranna Khanna was also vice president FOGSI. So thank you very much, all of you senior persons, that you have given consent and being a part of this panel discussion. And then we have Richa Sharma. She couldn't join today due to some issues. And then we have Dr. Priyanku Rai. He's the Public Awareness Committee chairperson. And then we have none other than Dr. Vijaya Lakshman Shashadri. And I'm so happy that she's joining from USA. There is the early morning. So this is a dedication for our women's healthcare. And then none other than we have a doctor. I am not able to. Dr. Bino Kushwaha, she is a professor in the Riva. And please, technical teams, see that all could be made co-host so that they can unmute themselves. And then Dr. K. Sunita, madam, that she is also associate professor in Tamil Nadu and had lots of experience. So, and then Dr. Kiran Agarwal, she is also associate professor in Delhi. So we all such a expert panelist, and they all are from different states. So we can see that we will have going to have their views and their recommendations in next few minutes. So as we all know that family planning program in India was the first country to launch this program. And then we know that on the every year World Population Day, we all emphasize all these things related to populations control. And then we all know that this is the whole population share of countries where we can see that the Uttar Pradesh, Maharashtra, Bihar, West Bengal, Andhra Pradesh, there is a major contribution from the population. And then this is the slides also we should keep in our mind, where we can see that the still today around 70% is the permanent female sterilization, and still only 3 to 4% IUDs, and 7 to 8% pills, and male sterilization 2.3%. So now, Dr. Priyanku Rai, you are here. So my question is to you. Ki, still, Dr. Priyanku, are you there? I think Priyankur is not there. है क्या Priyankur? All of you panelists unmute yourself. So Dr. Priyankur, I am not able to see him. So my question to him was ki still doing lots of efforts. What are the efforts? What we should do to increase awareness about the contraception? How and about what? Dr. Ranja Khanna, you can tell something about that.
Yeah, okay. Yeah, about what's the question? Please repeat. Actually, I was
Yeah. Anyone can take. Otherwise, I will tell
yeah.
you.
Tell me
Because
the question. Tell me the question.
question was that we are having so much of family planning programs for so many of years, but do we still need to increase the awareness
Yes.
about the contraception? And if
Yes.
yes, then how and about what?
Actually, it is all about females' awareness about contraception. I think we should make it a more a couple-oriented thing, and yeah, I don't think there is so much awareness still about contraceptive uses, because sometimes when you are counseling the patient, then you realize that not many people are aware. So I feel what is important is that more time should be devoted as much as possible to increase this awareness about contraception, so that we can have an improvement in the maternal morbidity and mortality.
Okay,
And
so
we
in
can
this
have
regard,
posters and all. Posters are there. We can have posters. There can be
yeah,
ads on television, and
yes. So
billboards
what?
should be
Yes.
there.
So in this regard, we want to just highlight that still amongst 46 million
I
women
just
are
want to
having
add
unmet needs.
here, Bharti,
Yeah.
Bharti, I just want to
Yes.
add here, adolescent also we get so many patients with unwanted pregnancies, right?
Yes.
So when we start with the sex education in the schools, definitely we have to take one topic on contraception. So I think the need starts right from the adolescent education part. So contraception is really unmet need for the modern contraceptives, and though the all the people they know by the advertisement and paper, no, so right use of these contraception in the right way, because they know about the emergency contraception, but they don't know about the use of condoms or oral contraceptives and when to use, how to use.
You know,
So,
one
Dr.
thing which is very surprising that I have noticed nowadays, emergency contraception is one thing that everyone knows about,
Yes,
even the adolescent girls.
everyone knows.
So people are using emergency contraceptive as a actually form of contraception.
So here, please.
Especially
Yes,
we
yes.
have to concentrate more in colleges and
Yes.
also in low socio-economic in
Very
villages
true.
and
Yes, yes.
also you have to go and tell
Even
about the
even
contraceptives and
villagers are coming using emergency contraceptives, and they keep on complaining of irregular periods. And when you go to the depth of the problem, you realize
And
that they are just using
that also
emergency
is
contraceptives.
available over the
So we
counter.
have, please,
Yeah.
panelists,
Yes.
please speak one by one, because all of us can hear you. And second thing that we have to remain very comprehensive, because we have 4-5 questions, so we have covered all these things. So till we get input, that of course adolescent contraception, emergency contraception, they need aware. But I just want to highlight that still 46 million women, they are having unmet need. So this is very important issue. We have to take care of that. And second thing that the government is doing the all posters and all banners and all advertisement, but still I just want to highlight the one thing that everyone we should know that still the government has policies, services level that target free approach, voluntary adoption of family planning method, based on felt need of community, children by choice, not by chance, more emphasis on spacing methods, assuring quality of services, expanding contraception choice. These all are our government policies, and they all are doing the immediate addressing the emphasizing on the immediate addressing the unmet need. Are you able to see my midterm TFR to replacement level up to 2.1 by the 2010, and as well as they are having the long-term population stabilization by 2045. So government planning schemes are very good, but need to be awareness because they have doing the expansion of the basket of family planning choice. They are doing the demand through ASHA scheme for family planning, promoting quality sterilization services, promoting quality IUCD services. This is the point, generating demand and awareness of family planning services. Here we obstetrician can contribute and addressing global commitments like we are doing all. And so definitely it is important that we have to emphasize for all the availability and access of our family planning methods, their side effects, health risks, and contraception for everyone. But here just one more thing, that as the family planning services and government of India, they have given emphasis on the equal responsibility to the women, men and women. That is also very important. So anyone, Dr. Shobha is there or anyone, is male participation has role? Please be specific and short because we have less time. Yeah.
Male participation definitely has a role, but as you have just told initially only, that male sterilization is only 2.4 as against 74% for female sterilization. So that means that males, there is something known as male ego, which is still very much prevalent in Indian society. So because of that, the males think since it is a more female problem, female-oriented problem.
Is only 2.4 as against 74% for female S.
What is
and the
this?
subsequent inference about male ego requires careful examination and context. Without
What is
knowing the
this?
source and specific details of these percentages, it's impossible to definitively say what male stabilization refers to.
Yeah. So that is what I was saying, that actually there's something known as male ego, which is still prevalent. And because of that, the males think that since it is the female who gets pregnant, so it is the female's responsibility to choose her the contraception to prevent herself. So that is why the male participation is very less, and we have OCPs, we have injectables for females, but we still the other male things are still not there. We don't have pills for males. We don't have injectables. Except for condoms, we don't have any other form of contraception where
One
males are
important
concerned.
thing that
Or sterilization and vasectomy, they're not resorting to.
Adolescent contraception as well as emergency contraception. The second very important point, that men's participation, because many programs, though the government is saying that they want the equal involvement of the men, but on the other hand, they are doing all the Saas Bahu Sammelan, Nai Pehal Ke, but they are not involving the male actually. So these things has been that still the male participation is less, so they should be aware about that. And we also in our practices, we can do by the communications, by the active participation, support during use, as well as couple counseling, and the options to telling there about the men for the contraception. And we all know about that. So next question comes to, is government basket is expanding their choices? Yes, so we all of traditional practitioners or in the government health sectors, mostly we know, but in the practitioners, we don't know about that how the women can get advantage of it. So Dr. Vidya, Dr. Kavita, please give some light on this.
Yeah, ma'am, I would just say when we talk about the government basket here, we have a lot of patients who are coming to us for vaginal deliveries, they're having cesareans and they're having MTP. So we should make it a point that when they come and when they go, when they're leaving our hospital, they should have chosen at least one contraception. We should see that none of our patients go without a contraception. So that would decrease the unplanned pregnancies, because they have the vaginal delivery or cesareans and then they come within 6 months, 8 months, they come back to us and now they come with an unplanned pregnancy. So that is one important point, that we should counsel each post-abortal, post-delivery or post-cesarean patient.
That is true. And other thing that we should also know we all should know that what is the available for the government baskets, and we should try to provide them access of the all women for that, like that we have now injectables and we have now so that they should get it. Dr. Shobha Gudi, she's here because she have some internet issues. If she's not there, then anyone can take that what is the best option for postnatal women for contraception. Very specific answer that what are the options and what you should help the woman to get it.
I think postpartum IUCD is a very good option.
IUCD, I think, is the best. Yeah. Yeah. Kavita, go on.
Yeah, ma'am, please.
Who is talking?
Postpartum IUCD will be good for postpartum IUCD will be the best method for these people, madam. If they are not willing for it, then we have to advise them about progesterone only pills. Low dose progesterone only pills will be better. But best one is PPIUCD for me.
Yes, so we are very clear about that. That we can use this is the recommendation that less than 6 weeks postpartum, then women can use all progesterone only pills or their devices.
Lactational amenorrhea method.
Less than 6 months.
LAM
Then
is
we
there,
can have
but how
breastfeeding women,
reliable
they
it
should
is,
use
that's
POPs or LNGs, or if implants they can use. But more than 6 months postpartum women, they can use the again the all progesterone only pills, as well as they can use the combined pills also. But again, for country like India, this the best thing is that if they can have a IUCD. And but on
Even
the same,
even DMPA is good enough. Injection DMPA.
and even they can want to take that, how does this make, because we all know all these things, but still women are coming with unwanted pregnancies. So how we can do some efforts to make it acceptable for women? Any special things by your practice, by your experience?
So I think we are giving every patient, we are trying to counsel for postpartum IUCD, but apart from it, if there are certain contraindications, like that patient is having chorioamnionitis or bleeding, or she had postpartum hemorrhage, such things in which patients in which we cannot do PP-IUCD, we can give them implant. So that will be for 3 years, and that will create a spacing of pregnancies. So I think these two are quite a good options, and they can both be given, because now implant is also available in a government facility. So I think both these options are quite good. And we also have the male partner to counsel along with.
Yes. Anyone wants to add something?
Bharti, your voice
Bharti,
is
there is a
echoing.
lot of echo.
There's a lot of echo, Bharti. You log
She
out
has
from
joined
one
from
device.
two devices. Two devices.
Yeah, log out from
She has
one of the
joined.
devices.
Now is okay?
Yeah.
Yes.
So anyone wants to add something for increasing the acceptance? So again, what we feel that we should have these all recommendations to our staff, and this is the MECV. We should be familiar with this, that what actually contraception we should provide the women to at what stage, and we should assess the other health conditions also. This is important thing, that we should try to give contraception also with evidence-based and with less side effects, more safety, and as well as counseling by the senior doctor is also very much important. So that is just a message we want to give, that we should utilize maximum services by the scientific-based contraception to our women, so that they can be more comfortable and more accessible and proper follow-up. Then what is about the post-abortion contraception, Dr. Rajna Khanna, madam, that the women can should not have unwanted pregnancies and they have
Post-abortion contraception, the best option is IUCD. Of course, if there are no signs of infection, then we can insert it immediately. And other options, we can have COCs, then DMPA can be injected, or we can offer even centrochromen, or progesterone only pills can be given. Of course, condoms are also a very good option. So we can go for all these methods. And of course, if she's had a medical abortion, then we'll have to wait for the all the abortion process to be completed. So around 15th day, we can go in for a IUCD insertion, provided we are sure that there are no signs of infection. Or we can even start the patient on COCs on day 3. So there is some actually controversy regarding DMPA injection. Some people are of opinion that the day you give the mifepristone, you give DMPA injection. But other people say that that could interfere with the abortion process. So it is advisable that you give DMPA the day you are giving the the misoprostol. So that way we can, but what is most important before an abortion is to counsel the woman. So counseling plays a very important part. You take her in confidence. You tell her that for another 6 months, you should not conceive now. Otherwise, the child is likely to have IUGR, growth restriction, premature babies. So it is not healthy if you conceive within 6 months. So we have to advise some form of contraception. But of course, if she refuses any contraceptive options, then we cannot deny her the right to for an MTP.
Thank you, Dr. Rajna. And here I want to highlight everyone that government guidelines that please, when even if woman is not willing to adopt some contraception, even she is not adopted, then still you don't assure the woman that she will not be refused for MTP. Reason being that she should not go for unsafe abortion. But we should continue to counsel her till she adopts contraceptive method. So this is very important, and this is the whenever you are giving the some abortions, especially the medical method, this is the government guideline charts, and the 15 days you can give. When you are giving the medical method, from the 3rd day you can start the contraception, even or after the 15th day when she has totally evacuated, you can start give the post-abortion IUCDs and all. So we should be remain updated, but of course counseling needs time. Then Dr. Kavita in the short that nowadays we have lots of things like long-term IUCDs. So is it replace the sterilization or still sterilization doing? So in what condition? What is the scenario if women are asking still for the contraception, or we can choose these LNGs also?
So here if we see the long duration LARC, they are preferred because they are effective, safe, and also they're reversible. And the one more point is that there are non-contraceptive benefits. But yes, tubal ligation is also here to stay, especially in those patients who are certain that their family is completed. That is one thing. And also, if we see there are few patients, you counsel them a lot, but then also they would say, we don't want to have any foreign body inserted. So they are not going to opt for copper T. They are not going to opt for implant and injections every 3 months. That is again not possible if she is to go for more 10 to 15 years before menopause. So I think here in these two conditions, when the patient is certain that her family is completed and she is not agreeing to any of the reversible methods, these are the two situations when the patients will agree to tubal ligation because they are not inserting anything foreign in the body.
Yes. Anyone about the role of emergency contraception? Dr. Sneha, Dr. Vijayalakshmi, or Dr. K. Sunita, you were trying to tell?
Yeah, emergency contraception is the most important thing which has to be given counsel. When giving counseling, you should tell every woman who are refusing to have any long-acting reversible contraceptives or tubectomy or other things. You will be giving backup by giving an easy pill to be used whenever there is a breach in the barrier or unprotected sex has happened within short time. Then we will be advising them about emergency contraceptive pills like easy pill or UGP method or other methods of contraception.
Only important thing is we should never allow, we should also counsel saying that this should not be a routine. Because it is so very easy.
And for that, we have to explain to them that if they use it routinely, then it is going to cause irregular bleeding pattern.
That is very important.
Efficacy also reduces with regular use, repeated use.
Definitely.
So again, what I have found the experience regarding the emergency contraception all over the countries, because of course it is a good thing. Many unwanted pregnancies can be prevented, but again, message should be very clear that women should know that this is not regular contraception, and they have some menstrual irregularities if they would be used regularly, as well as chances of failure are also there. But that is also otherwise, of course, it is a good option, but women should have with herself whenever it is required. Accessibility is also important issue. So next question to Dr. Vidya Madam. Of course, we have heard lots of things about the oral hormonal contraception. So just in a short set, what's new oral contraception we can give our women, or mala they are enough, or in the family planning basket some low dose pills are added or not, or is it required? Dr. Vidya, you are there? Dr. Vidya, तो भी मुझे Madam, you are there? हाँ.
Yes, yes. We have to. Hello, am I?
Yes, yes, yes.
I'm there, and am I audible?
Yeah, you
Yes.
So I was talking. Yeah. So I was talking about the oral contraception you have asked. So there are many things have come up. There is lot of revolution in the form of the dosages and what it content also. Means it contains estrogen, progesterone, and this so many actions. Means that there are cycle wise also we have and we all know the non-contraceptive benefits, their actions, and of course we give the MEC wheel according to the risk factors also. So there are personalized options which are available, and there are short acting also. Some things are available. So there is a lot of evolution has occurred in the estrogen content as well as the progesterone content, and we always give these things according to the, again there is a cafeteria approach, and we always choose according to the risk, medical risk of those women whom we are prescribing these oral contraceptives. Dosage wise also we can give 28 days cycle or extended cycle regimes also. And we all know about the mechanism of action. I need not tell you about these combined oral contraceptive pills. There are again advances apart from the regimes. There are non-hormonal contraceptives are also available. Okay, and these revolution have occurred right from 1900 and some I think 60 years,
Thank you.
65 or something
Yeah.
till now. So there are
And
so many
luckily-
advances they have occurred for dose, and even for polycystic syndrome. Means we are using for the other usages, again low dose estrogen, low dose progesterone, all those combinations are available in the market.
And I think
So-
now we have the good app with medical eligibility criteria. So
MEC,
anybody
yeah,
can put it. Yeah,
we can use.
based on the MEC. Yeah.
Yes.
So thank you, Dr. Vidya Madam. So I always feel that OCPs, and nowadays what latest OCPs and especially low dose estrogen plus levonorgestrel, and sometimes in cases of some cyclical issues or some PCOD and others, is the other options. They are really very good options. So we should have a perfect knowledge, and I think in future some medicines will come in the family planning program that would be good for our women. Then Dr. Sunita, Dr. Vijay Lakshmi, what is the scope of natural method of contraception barrier, non-hormonal? How much we should emphasize? Because sometimes the woman comes that they were using the lamb and they become pregnant. So they are
No,
not
actually,
yeah.
you are right. There is definitely a scope, but the only problem is, one is sometimes the failure rates are high because patient is not really knowing well about the usage of all these methods. In fact, we have the prominent coitus interrupters, which usually doesn't work, and for a joke they would say sperm can even go right from the thigh. So sometimes it's like difficult to really practice the coitus interrupters. The second method, of course, the lactational amenorrhea method works, but it is very important that there is an exclusive breastfeeding, and they should not leave a gap of about more than 4 hours between the breastfeed, and both breasts need to be fed and that is also very important. And sometimes, yeah, the failure rates are definitely high compared to the regular methods, but this is good for those who really don't want to use any hormones or don't want to use any as they said, the postpartum IUCDs or injectables. So it works, but the only problem is there has to be a good awareness. The other thing about the fertility awareness method, which also is a very important part of the natural family planning, I think very important to know about the cyclicity of the cycles and then advise her accordingly about the fertile period. And we know in regular cycles it's okay 2 weeks before, and then we all know about the fertility period. But in cases of irregular cycles, it really doesn't work much because we have to really calculate well about the duration of the fertility. The other very important thing that we must remember is sometimes these people do what they do is the ovulation kits, which they use generally to know about when they are trying to get pregnant. They also use for this, but that doesn't help because the sperms can remain alive in the body for more than 72 hours, and then eggs remain alive for 24 hours. So these basic things, I think we have to teach them well, and it works if the knowledge is good, if they are able to use well. The basal body temperature, cervical mucus, I don't think it is practically possible because basal body temperature will be, like showing after the ovulation, and there has to be a prolonged abstinence, so that again becomes difficult for them. And of course, the important issue is the barrier methods which come on, they come very handy. And here again, the couple counseling, as we say, is very, very important. And that's why the male partner gets involved here. Use of condoms, the use of even the female condoms, or even use of any other barrier method is definitely important, because it also prevents the infections or HIV, whatever, the sexual STDs. So that is another advantage. But I think it does have a scope. The only problem is there has to be a real education imparted to the patients about this, and they should be really aware. Now, looking at the cervical mucus and all, I think even as a gynecologist, we are not very routinely using these nowadays. And for the female to really keep wiping at the cervical mucus and looking at it is not practically possible. So these are methods available, but then they have to take it with a little bit of extra knowledge. And we should always tell them if the failure rate is going to be there, they should be able to either reach us very early for early terminations, or they should be able to carry on with the pregnancy. I think immediate postpartum, as we have discussed enough, there are the other methods which we have to make sure that they don't become, because lactational amenorrhea has been there for years and years. In the previous generations, people used to always talk about lactational amenorrhea. So they are in the routine, in the family itself, they have that knowledge, but not every time it may work, and there could be gaps, especially because nowadays the working ladies are really not doing too much of exclusive breastfeeding.
Thank you, Doctor. Thank you,
No,
Doctor.
I think with the normal physiological methods, the chances of failure are very high, because sometimes, though we can predict the ovulation, even if the cycle is very regular, but sometimes because of intercourse, the ovulation can always take place much earlier. So too much dependency on the physiological methods, even though the patient may be having knowledge, is a bit risky, and it should be taken with a pinch of salt, because these variations will be there and the failure rate will become quite high. So we have to explain that also to the patient when we are taking that into consideration.
Yes, and only on that matter, women should know that what is the risk of pregnancy and all things. But of course, knowledge is important because they are free of side effects. And if a woman is using the lamp and with that they are using the IUCDs or other things, then it is good. So yes, we should be all have a proper knowledge of all these things, and women should also have. Then Dr. Beena Kushwaha, I am not able to see her. Madam, are you there? Dr. Beena, madam?
Priyankur has joined now. You can ask
Acha,
him.
Priyankur add हुए. Dr. Priyankur, are you there?
Yes, ma'am, I'm there, ma'am. I just landed
Okay,
and
you are there. So,
connected. Thank you.
okay, we have, in fact, first question I have kept for you, that as you are public awareness committee chairperson, so how much important you think that nowadays we need the, of course, awareness of family planning, how, what FOGSI is doing efforts and how we can do with government. In a short, you can tell just that if you have joined.
Yes, ma'am.
Or
Yes, ma'am.
anything, what you think in the discussion, what you want to share with us.
No, so I will share about what you just asked me, ma'am. So if you're asking, first of all, you asked me about the FOGSI. So what FOGSI is doing about the public awareness, about contraception. So my good friend Dr. Ashish Kale, he is the chairperson of the family planning committee, and there have been a lot of meetings that he does with the government of India. They have brought in the intramuscular implants as well. The implants which will be soon into the programs of the government of India as well. Plus, we know about LNG IUS also, which has been one of the things that my committee, along with, of course, with the permission of the presidents of FOGSI, the three presidents that I worked under, Dr. Rishikesh Pai, Dr. Jaideep Tank, and Dr. Sunita Tandulwarkar, ma'am, we have gone a long way with them with Bayer, and then LNG has been incorporated in many medical colleges as a training tool for the postgraduates. Plus, it has been incorporated as a free device which can be used in many government setups as well, government hospitals. So that has gone a long way towards the contraception benefit, of course, in addition to the treatment of benign gynecological disorders. So I think, ma'am, in short, if I say, I think it has to be a hand in hand of FOGSI, hand in hand with the other aids like USAID and other Japaigo and other companies which play a part, IPAS, which has a good role in abortion care, etc. So I think all of this together can definitely join hands, and then together we can succeed. But the most important thing of all is spreading the knowledge, as Ranjana ma'am was very correctly saying. We need to spread the knowledge. We may provide a lot of services, but if people do not know, then it's of no use. There are a lot of social media influencers, there are a lot of political leaders, there are actors who talk about it, who give information on TV, on radio, etc. But ultimately, whatever may be the route, the spread of knowledge, spread of the awareness, spread of that these services are available at a low cost or free of cost and they're beneficial is something that we definitely need to put across to all the people across the country.
So that is true. Dr. Ashish Kale, have you joined her? Dr. Ashish, you are there? I think he is not there. Is my presentation is there?
Yeah, it is still there.
Are you able to see?
Yeah.
Okay.
Yes,
So, okay, I am not able to see
Barrier
my presentation,
methods.
but it's okay. Okay. So, any one of you that if woman is in the comes for the second trimester pregnancy and for termination, and because we are talking about the safe abortion services also, and she
There is a
wants
woman by the
that
name of Dr.
18 weeks
Ashwini Kale.
pregnancy. Yeah, Dr. Ashish, you are there?
Yeah, Dr. Kale has joined.
Okay. Dr. Kale, you can hear me?
Yes, I can hear you.
Okay, so I just want to, because we are just discussing what topic you were telling to tell us. So we have discussed the contraceptions. So what do you think as a public awareness, public family planning committee chairperson? See, actually, what things should be emphasized for increasing acceptance of contraception, as well as according to in the background of current scenario of contraception in country, in short?
The thing is that, madam, when we talked about the India as a populous country, it started from the 1 year back. And when I met our secretaries, health secretaries of India and another NGOs, what I found out that India is the country where there is a vast population. Along with that, there is a vast religious difference. So every person and every community has a different acceptance rate and their beliefs about the contraception. So if we wish to increase the uptake of the contraception, what I believe that one should be very much apt that every should know the details of it. It should go with the grass root levels. And secondly, it is one thing cannot be fit all. So similarly, the every need of the contraception for every population is different, and that has to be discussed from the adolescents because that is the first step into the contraception practices.
Right. So, very true, you have told us that we can increase, we should know all about things, and it is not only that we are taking the, yeah. So, just I am sharing my, so next question to Dr. Rajna Khanna or anyone can else take. that if woman comes to you with the 18 weeks pregnancy for termination, for 18 weeks pregnancy, and she wants that she has a contraception failure for the termination. So actually what we should have all approach, what we should think we should be checked, that is something about just update anyone.
Whether they have come for after sex determination, we should find out first.
Yeah, that is most
Many times
important.
it is the most common cause for coming in that period of gestation.
After 16 weeks, mostly it is sex determined only.
So how? So now I just want to
we have
tell
to take
you.
her,
So will you
previous
refuse the woman that you will not do?
No, family history has to be taken, and we have to see the sex of the. Sometimes they'll say that they have a son, and all the time they have actually only daughters. So this is a very burning problem nowadays in our country also, which we are facing, that the patient has had a sex determined and she comes to you.
So here just I want to, anyone wants to add something? You can add. Dr. Ashish, you want to say something about that? Because if woman is coming at the 18 weeks with the for the termination and she is saying that she was not knowing that she is pregnant and it is just contraception failure. So should we intensively we should interrogate that woman, and or we should give her safe abortion services? How we should approach such women?
We can
Dr.
do
Ashish?
it. Sir is not there.
Actually, I think I just want to share about the guidelines of governments and all.
We
That
can do it.
preferably government says that till you don't have a very clear evidence, you should trust on a woman. And again, safe abortion services should not be jeopardized in preventing sex selection. So you should not be biased that even if woman is having two girls, so she would be definitely by ST. So you should check it. You can approach is that first you, just as madam has said, that a clinical evaluation, confirm her gestational age and evaluate the eligibility of her termination, and then counseling, and again non-directive, non-judgmental counseling, and about the methods of termination, then the informed consent, and then of course legal consideration. We all should know that actually what is the gestational age, and at what gestational age what forms you have to be
So
filled.
is there any legal implication for the gynecologist or the obstetrician who is doing it? Because, she is doing a case and we have not gone into the details. We take her for face value and actually it's a sex determined pregnancy. So is there
No,
any legal
see,
implication for the obstetrician doing it?
no, as long as primarily she has not approached us with that thought, then we are not responsible for that. If we are not aware that she has gone for it, we need not worry about it. I mean, she has come for the abortion services, termination services. We are doing it on case-to-case basis because she needs it. That's it. I mean, what is behind her, in her mind, and what is in her family, and what has happened. And because after all, if sex determination has been done, it has been done by some other doctor or somebody. They are responsible for it. We are
So
here.
that is, Dr. Sheshadri, that is number one scene. Now the second scene is that the patient comes to you at that term and then she says that she has had a sex determination done and hence she
Then
wants
definitely you will not do. Then definitely we will say that it should be continued, because sex determination is not indication for termination of pregnancy.
Exactly.
That is
There
very
are some
clear.
people who come and blatantly tell you
No,
they
that
have
is
found
very
out,
clear.
then you
No,
have
I
to say a
think-
big no to them.
No, I
So,
think they
yeah,
are
it is
quite
very clear.
aware, because whenever the ultrasound is done, it is a responsibility of the sonologist. We know to make them aware that it is no sex determination is allowed in India.
Yes.
So,
So,
see,
we-
sometimes they go all the way, travel to Singapore or somewhere, Dubai, and get the sex done, and then they will
Right.
come. But then they know that they cannot reveal it openly. And in India, it is really not allowed. So they are going to come. And if you don't know
So
on
that
the
is,
face
yeah.
value, so you
So
don't
that is very important. We have discussed these things that we should preferably think thoroughly and without doing biased, and we should maintain all documentation. That is very important. If women come for the MTP, first you check her gestational age, eligibility, then you see whether you are doing eligible or you can do at your sites of that particular gestation age. And then you have to take the informed Form C. Consent on the Form C is very important in the documentation. And then you have to complete the Form 1 or according to gestational age. Provide her MTP services. Form C and Form 1 should be placed in a sealed envelope, and the confidentiality has to be maintained. And in the medical methods of abortion, if woman is not already taking the pills or incomplete abortion, then all medical method abortion, all documentation has to be filled. So this is the mandatory documentation you all should know. Form C, Form 1, Form D beyond 14-24 weeks, and Form E 20 to 24 weeks. All of should know all these forms, and these all things are available on the ICOG website. In ICOG campus, all forms are there for recent MTP Act. Form 2, head of the hospital has to send in the end of the month, regularly. And Form 3, all have you, the 2 columns. This is the ICOG MTP Act clinical implementation. All forms are in this, and this is available on the FOGSI website as well as FOGSI Focus. Both things are there. Confidentiality, I just want to emphasize that confidentiality is now very much emphasized when you are practicing the MTP. So please take care of this, that the woman, if she is doing, you are doing the MTP, then give her some enrollment number, and that should be entered in all registers. And again, MTP permission based on pregnancy duration. We all know about things. I am not going detail. Then again, medical board, we should be aware, all of us, that beyond 24 weeks, the permission of medical board is required. And as time is over, in the last one important question, I just want to share with all of us, because we all know that if beyond 24 weeks we do the termination, so what we have to do of fetus. So here the recommendation is that no legal allowance for active euthanasia. Actually, doctor must preserve life if baby is viable, avoid neglection, provide full medical support. And here it is said that there is a there are some authorities where if baby is beyond 28 weeks and live, then with the permission of that authorities, it baby has to be handed over to that community. So if 24 weeks permission, MTP is permitted, special categories case based on viability. 28 permitted by a board, fetal anomaly viable, then neonatal care. 30 court mandated and critical fetal issues viable, full protection. So finally, the follow confidentiality at every step. Court and medical boards are critical after 24 weeks. Always uphold ethical and legal standard. All these things are your FOGSI, focus recently ICOG campus. You can go through all these, and you have all documents. Whatever this is in the details. MTP Act 21 clinical implementation. You have all information regarding that. And this is available on the FOGSI website. So in the last, of course, we obstetrician, though we know that it is difficult in the societies, that if you do the MTP sometimes and police comes to you and judiciary comes to you, why you have done this, and we have lots of sometimes humiliations and wastage of time and energy, but still we have to do it, because to prevent the unsafe abortions as well as related mortality, morbidity. But again, we have to take care of proper counseling, documentations, that even woman is saying that with their she's adult, and with the voluntary consent, they have a issue. But still you take the consent, that is, we don't need any medical interference, we don't need any judicial interference, and it is by our consent. You take all this consent. Again, for though law is not there to take the Aadhaar card for age, but again, as the POXO is there, so you just confirm the age of the woman. And documentation forms, consent form is very important. And of course, improving skills. We have talked in today's webinar that how we should learn for the medical methods, surgical methods, so minimize the complication. But again, chances are there. So please take care that where you are doing the MTP, that site should be approved, and you should also be eligible for doing that. And know about Act. There is no excuse for your ignorance or innocence. So that is the issue only, that सुरक्षित हो गर्भपात बेटी बचाओ के साथ, कि both things we have to balance. That's preventing the sex selection, the safe abortion services should not be jeopardized. And nowadays, woman-centered approach, as they say, that devote adequate time of counseling. This is though very smart line, but it's not practically feasible. We all know, but we have to make it. Maintain privacy and confidentiality. Most of the time our OPDs, they are not maintaining proper confidentiality, so but we have to develop this. Use safe technologies, MVA, EVA, medical methods. Follow standard protocol for infection prevention, pain management, and management of complications. offer post-abortion contraceptive services. Contraception services should be started from the first day when women come for the abortion, and during whole procedure till end she doesn't accept it. Provide reproductive and health, other health services, counseling, and services tailored to a woman medical and personal need. This is a government recommendation. So in the last, we all together, all obstetricians, we know that family planning in India is the way forward. Actually, an annual increase of 0.4% will be achieved in modern contraceptive method. Will be attained for 54% of protection rate. So you can know how big figure is. And rolling out of injectable contraception, progesterone only pill, and or meloxifene means Saheli, they all in the public health system are the revolutionary, delivering quality assured services to the hardest to reach in rural and urban areas. So increasing awareness and demand through 360-degree communications campaign rollout across all states of India. Government is doing lots of efforts, FOGSI is doing lots of efforts, all of us are doing lots of efforts, and we know that family planning is alone could bring more benefit to more people at less cost than any other single technology available in the human race. So together we should create a world without unintended pregnancy. So thank you very much, all of you.
Ma'am, just
And
one thing. Can I just say one thing?
yes, anyone can say.
If we do MTP of around 26, 28 weeks pregnancy because of multiple GCA and the baby is born live and needs the new nursery ICU care, then what to do? The parents are not, the mother is not interested. The baby had multiple GCA. She said, I came for the MTP and now you are giving me a live baby which needs nursery ICU care maybe for months. Now what to do in such a situation?
Beta, Dr. Kavita, there are lots of questions that come individually according to the case. Where if someone is there, so they should help their medical boards or their CMO. But it is said that if if a fetus is congenital anomaly, you know that already. Then of course you some guidelines it is written that, or WHO says that here you can take steps before termination, that if you want to give some medicines for cardiomyopathy or something like that. So that could be.
Actually,
If it is
yeah.
congenital anomaly, that is written. And Dr. Kavita, please see that, FOGSI ICOG campus. We have given all these things in that detail. But again, anyone can challenge anything. So, because there are certain gray areas, always two parts. So women, couple consent for everything is very important. If fetus is congenital anomaly, then you can give potassium chlorides and all things at approved places, at good places it is mentioned. So if every case is different. But if like rape victim and she is about above 30 weeks of pregnancy, 28 week baby is life, then they have
No,
to
I think
you can.
I think it is important that we do a lot of counseling and take consent. Even in your routine case sheets, you can get it mentioned that we counsel regarding the condition of the baby. If it comes out, it could be alive, or it could be with a multiple anomalies. So, what is the destination for those people? I mean, you can really talk about it earlier, so that you are not, it takes a little bit of time for the termination to happen. Meanwhile, you just talk to her whether if the baby comes out live with multiple anomalies, what do we do? So we have to really make the decision earlier and then take the patient and her family or her husband, whoever matters, to a complete confidence, and then get everything done, so that you must expect that the baby may come out live nowadays. And if suppose the baby needs an ICU care, whether it needs to prolong the life, whether it is worth, what is the expense, especially from the money angle. You cannot be funding for all these people. So obviously, and sometimes a little later in pregnancy, say 30 weeks, 32 weeks, there are services which offer to take the babies in unwanted pregnancies, and if the babies come out live. So very, very important is the counseling, talking about, getting signatures, knowing about the whole situation much ahead, and don't find yourself. Otherwise, yes, all guidelines are very clearly nowadays written everywhere.
Ma'am, I will
Yeah,
just
very good.
reiterate what Vijay Lakshmi ma'am has just said. I think the most important part of the whole thing is counseling, because as we counseling, take a proper consent. That is, I think, the most important part. And whatever termination we do, ma'am, whatever termination for whatever reason, if it is after 24 weeks, we should not forget the MTP Act. Please follow whatever laws are there, because ultimately we will have to follow laws, because laws are the only things that will save us in time of trouble. So we cannot do
Agree with
something.
Doctor.
Cannot be only
Agree
we
with
cannot be
Priyankur.
only
Yeah.
we cannot be only empathetic to the patient. We should be empathetic, but also make sure of the important thing today is safe mother, safe baby, and also a safe doctor, because the safe
Yes, we
doctor is
should be
important. Following the
legally
rules is
very,
important.
we should be legally very protected.
Yeah, and we
whenever
should
we
not
do something.
worry. No, and we don't have to worry about the law. See, law is there to protect us. We should not be
Protect
scared
us,
of the
exactly.
law.
Exactly.
The law
So
is
we
there
should
to
follow
protect
the
us.
law. We should follow the law.
Absolutely. Exactly.
So thank you very much for wonderful discussion. In fact, still I found whenever we talk about the MTP and contraception, the maximum discussions and maximum person we joined. But still we always I think that whenever there is a confusion, that as Dr. Priyankur said, that we should know the act, we should follow the act. And second thing, that we should take help of CMO of your areas. What I came to know, that he is the authority. He is the ultimate authorities, and beside that, where the medical board is there, you should take help of. But even you should think with proper documentation than formalities. So thank you very much, all my esteemed panelists.
Thank
Yeah.
you, ma'am.
Thank you for
Thank you,
having us
ma'am.
here. Thank you.
Yes.
Thank
And
you.
thank you, Dr. Priyankur, Kavita, Dr. Anjana. And I can see, Dr. Jyoti madam is, joined till end. So that is what I think that, thank you, all of
ma'am.
you.
Thank you
Thank you
so
very
much.
much.
Thank
Dr.
you.
Vidya
Bye.
madam, thank you very much. Dr.
Bye,
Ashish,
ma'am.
I can see you. So I know it was, today was a difficult day. We all are busy in some issues, but still we have given so much of time to. Dr. Vijay Lakshmi, Dr. K.
Thank
Sunita,
you.
they all have given very much good input. Thank you. Thank you very much.
Thank you.
Thank
Had a
you.
wonderful
Thank
job.
you, ma'am.
Okay. Bye.